Welcome to EuroPCR 2016. My name is Michael Haude. I'm here with Thomas Zeller. We were to focus on the topic of revascularization in critical limb ischemia. Thomas, what kind of dedicated access scenarios we have for this particular topic?
Well, critical limb ischemia is mostly linked to below the knee artery disease, which at some time point develop either rest pain or non-healing wounds. And for this specific lesion location, it's very important for the acute technical success to have a very straight access to the lesion. That means what is usually preferred is an antegrade access. That means puncturing the common femoral artery in an antegrade fashion, or even selectively puncturing the proximal SFA. Reason for that is that the so-called crossover access, meaning coming from the contralateral access artery, is associated with a lot of problems with regard to steerability, pushability of devices due to a frequent tortuous iliac anatomical condition. That means we have a lot of torque bands and curves which reduce then steerability and pushability of the devices. So the antegrade stick is essential for success in those below the knee interventions. In addition, it's very important that you have enough success. We are dealing with a vessel pathology which is very similar to coronary pathology, meaning we are dealing with small vessels, we are dealing with calcified lesions, with CTOs. The main difference as compared to coronary intervention is the lesion length. Well, lesion length can be up to 40 centimeters. So we need excellent push, and for that purpose what we prefer is the use of guiding catheters, very similar to coronary procedures, straight guiding catheters, 5 French in dimension, together with 14,000 guide wires and rapid exchange balloon devices.
Are there dedicated devices that improve your acute and long-term success of this procedure?
Well, basically the industry obviously is offering so-called dedicated below-the-knee devices, low-profile devices. But nevertheless, for example, the profile of any coronary balloon is superior to the profile of so-called dedicated low-profile balloons for below-knee applications. So the basic strategy for treating, for example, below-the-knee CTOs is using a hydrophilic coated 14,000 guide wire together with a coronary balloon to cross the lesion step by step, either in the true lumen or subintermally. And then we switch to long dedicated below-the-knee balloons to dilate these long lesions. These balloons have a length up to 22 centimeters, and we inflate those balloons for up to 3 or 5 minutes to improve the acute success.
At the coronary level, we have seen that we improved our success rates significantly by the option of a retrograde approach. Is there something similar on the below-the-knee level?
Absolutely. We are more or less mimicking coronary retrograde strategies by using collateral vessels. For example, if we have a patent peroneal artery which is connected to the distal segment of an anterior or posterior tibial artery, and if this collateral vessel is not too tortuous, you can use this collateral vessel as kind of retrograde access to a CTO of the anterior tibial. We can use the foot arch if it's closed for retrograde access. So this is retrograde access technique similar to coronary procedures without using an additional stick. The other alternative, which is becoming more and more popular, is simply to access the distal reconstituted artery, either guided by ultrasound or simply contrast injection, sticking into this distal segment, which is reconstituted distal to the occlusion, going in with a 18 or 14,000 guide wire, crossing the lesion from retrograde. We can even dilate those lesions from retrograde and then finish the procedure from the antegrade stick. So retrograde access techniques in different variations have clearly improved the acute success rate for below-the-knee interventions.
Where are the unmet needs in this field?
Well, I told you we have significantly increased acute success rate, so there's almost no kind of lesion which cannot be tackled successfully acutely, but the key challenge is patency. Patency is difficult to achieve below the knee. We have only one reliable device available for a limited number of lesion subsets. That means we can implant coronary drug-eluting stents in lesions up to 10 centimeters. For these kind of lesions, we have evidence that we can significantly increase patency. But when we are talking about critical limb ischemia, we frequently see very long-distant CTOs. And opposite to what we have seen in the superficial femoral artery, so far no drug-eluting balloon has shown efficacy below the knee. So this is the big unmet need to find a technical solution to, in long term, sufficiently treat long-distant CTOs below the knee.
So by this I would like to thank you very much for this interview. Thank you.
You're very welcome.